I'd like to welcome you to the Managing the Revenue Cycle Process session here. We've got a great panel for you today. My name is Schimel. I'm an associate here at Garfunkel Wild in the Managed Care Department. And I'd like to introduce Michael Orseno. He is from Acuet RCM, which is a medical revenue cycle management and consulting organization. He has nearly 20-year career in healthcare revenue cycle management. And he has worked to transform the medical facility business office with advanced automation, measurement, and staffing best practices. Next, we have Colleen Hedrick, a credentialing manager at Garfunkel Health Advisors. Garfunkel Health Advisors team provides support to address various needs within the healthcare industry. Their expertise includes medical coding, auditing, revenue cycle management, compliance. And Colleen has been handling the healthcare payer enrollment process for practices, physician types, facilities for nearly 20 years. So we've got some good expertise going on here. And with that, we'll just jump right into it. Michael?
Appreciate it, Ellie. Thank you so much. And thank you, Garfunkel Wild, for allowing us this opportunity to talk about revenue cycle. Unfortunately, my bio seems to be a little bit outdated, and not to date myself, but it's now over 25 years. So at any rate, the goal of the presentation here is really to not just understand the revenue cycle, and we're going to go through revenue cycle benchmarks, and we're going to go through some different audit types. And particularly, we're going to talk about a reimbursement audit, define it, and talk about the steps in it. But really what we'd like for the audience to have a better understanding is, as a provider, how do we know if whether it's an outsourced RCM company or if it's in our in-house staff, how do we know if they're doing a good job? And so hopefully we'll be able to answer that question by the end of this presentation. That's the goal, at least. So some of the common revenue cycle benchmarks are days outstanding, or sometimes called days in AR, percent of AR greater than 90 days, claim lag, or sometimes it's called billing lag. Then we have a gross collection rate and a net collection rate. Now, admittedly, this is not an all-inclusive list of RCM benchmarks. There's many, many more that you'll see, sometimes called KPIs, but these are some of the most common ones. So let's jump into it and start with days outstanding. In its most basic form, days outstanding is essentially the time it takes to get a claim paid. So when you see a days outstanding of, say, 35, you're talking from the date of service until, and on average, it takes 35 days to get a claim paid. The calculation that we use to come up with that days in AR is you take your total accounts receivable and you divide it by the total charges from the last 3 months divided by 90. So basically your average charges for your last 90 days. And the calculation, that's the most common calculation. Now, this calculation can also be done, your total AR over 30 days, over 60 days, sometimes over 365 days. But the most common form and calculation of the AR is overnight, is your average charge amount of 90 days. Now, our standard, we'll always tell you the standard. Our standard is 30 days or less. Keep in mind that when we're going through this and when I'm presenting this, it's really from our point of view and from our experience. And just to give you a little bit about Acuet, we deal exclusively in the ASC arena, the ambulatory surgery arena. So this standard may be more or less depending on whether you're hospital or if you're a physician practice or anesthesia, different types. But again, our standard is really going to be focusing on in the ambulatory surgery arena. The days outstanding or days in AR metric, the way we use it is it really determines the health of your AR, right? So how well is my business office functioning? How much are they? How are they collecting? Are they doing it efficiently or not? When you start seeing wild swings of your days outstanding, it may highlight a billing or a collection problem. The next one we're going to talk about is percent of AR greater than 90 days. The definition of this is the amount of money as it relates to total AR greater than 90 days outstanding. The way we calculate, it's a very simple calculation. You take your, you add up your total AR greater than 90 days. And typically you'll have a report that gives you the AR in buckets. So you want to take that in the 90 and the 120, the 150 and the 180 plus, add it all together, and then divide it by your total AR. Again, our standard is less than 15%. Again, in the ASC arena, but really, 15% is a good number, I'd say, across all specialties and types of providers. If you are heavily contracted, this would be a number that you'd want to shoot for. If you're more out of network, or if you have a higher population of workers' comp or Medicaid even, then typically we'll see that standard 20-25%. The way we use this metric is when you see a percent of AR greater than 90 days, that's high. That's higher than 20, 25, 30%. May emphasize an issue with patient collection or insurance denial. So if your staff or your AR team is not going after patient balances, if they're not collecting up front, or if they're getting a lot of denials, you may see that percent of AR creeping up month over month. The next metric that we'll talk about is claim lag, or it's sometimes called the billing lag. And this is the time it takes to get a claim sent and billed. And we're not going to be confusing this with, there's two different lags here. The lag is one to get the charges entered, and then the billing or claim lag is the time it takes to get it sent. These should almost always be the same. When you get your billing lag and your charge entry lag, they should be equal to. If you're finding a difference between the two, that means there's time being spent when the charges are being entered and no one is actually sending out the claims. So they should be always sent out the same day that the charges are entered. The calculation is the number of days from the data service to the submission of the claim. The billing lag, or the charge entry lag, is the data service to charge entry. Our standard is less than 3 days. And again, when you're looking at through the lens of an ambulatory surgery center, 3 days seems probably high for a physician practice, but in our world, we have to typically wait for the doctor to dictate, and then we have to wait for we go dictation, and then we go coding, and then 24 hours are typically in each one of those. So 3 days is less than 3 days is typical, and that's what we'll see in most of our centers. When you see higher numbers than this, usually you see a problem with the physicians not dictating on time. Is typically the main factor. Now, when you're looking at a physician practice, for instance, you don't have the transcription and the coding pieces. That takes some time. Typically, you have an EMR, and the physician will just be checking it off the CPT codes, and they'll be able to move right to billing. So with a physician practice, I would expect us to see 1 to 2 days is the gold standard. And again, the way you use this metric is you determine how quickly charges are being sent. If you have a high claim or a charge lag, it always has a negative impact on days outstanding. So think about it this way. If you remember back to days outstanding, it's the data service to the time to the zero balance, so it gets paid. If your billing lag is 5, for instance, that means you're adding 5 days on top of your days outstanding. So a really easy way to decrease your days outstanding is if you have a high claim or billing lag. Reducing that, every day you reduce your claim or billing lag, you reduce your days outstanding. Gross collection rate. Gross collection rate, very simple to calculate. The definition is percent of total charges the facility collected. The calculation is just your total payments divided by your total charges. There's a reason why we don't have a standard in this, because it really relates to the practice or the ambulatory surgery center's charge master. For instance, if you have a CPT code that's, you know, in one practice is $1,000 and in another practice it's $5,000, and you collect the same amount, the percentage is going to be different. And so really that's why you cannot, when people ask you the gross collection rate, it's irrelevant to even try to compare them across facilities. Now, however, it can be useful in comparing month to month in the same facility, right? In the same facility of practice. So if you're seeing your percentage typically is 34%, and then you start seeing it at 33, 31, 30%, then you can look at it and say, why is our our gross collection rate decreasing? It also can be useful for accounting purposes. So if you want to kind of roughly determine how much we're going to get paid in a particular month, you could take your charges and apply your gross collection rate to that and determine roughly about how much we're going to collect. Or if you have a gross AR sitting out on the books and your gross collection rate's 34.6%, then you can apply that to your gross outstanding and determine how much of that you're going to collect.
Michael, with this standard, obviously there could be changes month to month. At what point do you consider like 1 month a drop being just sort of a blip, and if it recovers after that, things are sort of fine and you can just keep going along? How many months in a row would you start to get concerned if you see things shifting?
I'd say 3 months, Allie, but I'd also say, you know, within a certain standard deviation, right? Like if you're seeing a 15%, you know, drop in 1 month, then you're going to look at it really closely. But if, you know, if it's a couple points here or there over, you know, 2-3 months, then after the third month, I'd take a look at it and say, what's going on with this? And there could be some very plausible explanation of why it has dropped. But yes, you certainly, after the third month of a couple points, then I would start looking at it. Finally, the last benchmark we're going to take a look at, and the one I highlighted in red, because it's one of the most important ones, is that's your net collection rate. And the net collection rate is the percentage eligible money that the facility or practice actually collected. In other words, how much of what you were supposed to collect did you collect, right? So your contractual rate is $1,000. How much of that $1,000 did you collect? Has no matter on what your charge. If your charges are $5,000, doesn't matter. If you're supposed to collect 1,000, how much of that 1,000 did you collect? So the calculation is your total payments minus over your charges minus your contractual minus your bad debt plus refunds, and that denominator is essentially your contractual, right? Our standard is greater than 97%. And that should be for really any institution, whether it's a physician practice, ASC, anesthesia, hospital, whatever. You should be collecting the upper 90s of what you're supposed to collect. And this really determines how well your business office staff collect on contractual amounts. And really, when they talk about how much money is left on the table, this is it. This is your net collection rate. So, you know, even our standard, we're leaving 3%. We like to be closer to 99, but, you know, we want to be a minimum 97%. You know, a lot of times that 3% is sometimes if you have a patient who just doesn't pay. You know, we get those eventually sometimes, you know, and you get a insurance that it gets denied for whatever reason. So, you know, that's where that 3%, but really you want to collect, you know, close to 100% of what you're actually owed. So we have audit types here, and some of the most common types of business offices included billing audits, denials, follow-up, payment posting, coding, and reimbursements audits. If you're conducting a billing audit, what you're really looking at is you know, what were the charges entered correctly? Were the modifiers appended appropriately? That's most of the time, you know, when the coding comes across, they're essentially just copying the codes of what came from the coders or from the physicians in a private practice. But the more important part of this is, did they append the appropriate modifiers? And again, we're looking at billing lag too. Was the billing lag where it should be? Okay. When you're looking at denials audit, you want to compare your denials month to month over month and making sure that, you know, they're not increasing like we talked about in previous one of the benchmarks. So, when you're getting denials, you want to make sure that want to look at are the denials, one, are they being worked appropriately? And two, are the denials being communicated to the front end, right? So if we're getting denials on a lot of times we'll get denials on Medicare number wasn't entered appropriately. So we want to make sure we're communicating to the front end saying, hey, that the number has to be inputted in this specific format, or we need a social security number, or if it's a workers' comp, we need a date of injury, those kind of denials. Feeding that back to the front end to make sure that they don't happen repeatedly. And so that's why we want to compare month to month. If we're doing a follow-up audit, we want to make sure the follow-up, this is a follow-up on AR, is it consistent? Is it relevant? And is it correct? You want to make sure that they're doing it, once every 30 days is our standard. Make sure that follow-up is relevant. Are they doing it appropriately? Are they just not saying the same thing? Are they taking active steps to get the claim paid? And is it correct, right? When we're talking about a payment posting audit, we're looking at, were the payments posted line item, meaning like if there's many different CPT codes, like if it's a surgery, for instance, are the payments applied to each of the different line items or CPT codes? Are the proper steps taken on underpayments or denials? So when they're posting the payments, they're making sure that we are paid appropriately, right? And at the time of payment posting, and also if we weren't, what steps did that payment poster take on an underpayment or denial to make sure that it doesn't fall through the cracks and no action is taken on that. A coding audit. Now, coding audit's very difficult for most of us to do. I'll tell you, I can't really perform a coding audit because I'm not a certified coder, but you really want a certified coder doing these, and I would recommend doing them at least once a year, if not twice. And we want to make sure the correct codes are being billed and the correct codes are supported by the documentation. For surgeries, obviously, they need to be in the op note. If it's not in the op note, they cannot bill for it. And finally, the one that we're going to talk about, and the one that's most common, is the reimbursement audit. Were you paid correctly on the procedure or the visits that have taken place? So, as I said, the reimbursement audits, they're the most common, and they're really conducted to determine if the facility was paid what was contractually owed, or was paid sufficiently if they're out of network by a third party on billed CPT code. So, obviously it's easy to determine if you're contracted with a payer, because you have, for every CPT code, you'll have a certain amount that you're supposed to be paid. Now, out of network is a little more difficult, but out of network, you just want to be sure that you are sufficiently paid. If you're being paid, typically, if they're being paid a percent of charges, if they're being paid, 10, 20%, you probably want to look at that to see how you can increase that to closer to 50, 60, 70, 80 sometimes. The metrics that are associated with a reimbursement audit are days outstanding, percent of AR greater than 90 days, and net collection rate. The reimbursement audit should always be conducted regularly, whether it's weekly, bi-monthly, and that's really at a minimum. We have our staff, we have leads that conduct these audits on our billers and collectors weekly, and we have our managers that do it bi-monthly. So you want to make sure these are done regularly to make sure, because this is one of the most important, to make sure that you're being paid correctly. In order to conduct this audit, you got to be proficient with your payer contracts, your rules, your carve-outs, multiple procedure discounts, and state, federal, or payer laws. So, you won't be able to determine, you can't just look at, if CPT, 63456, you're paid $1,000, well, that's great. You got to know, like, for instance, Medicare, they'll pay 100% on the first line, but they won't pay 100% on subsequent lines. They'll pay 50%. So unless you know those multiple procedure discounts, you're not going to know how to audit and be able to determine if you're paid correctly. And obviously, when you're just looking at whether you're paid correctly, it's not going to address whether it was billed correctly. For instance, if like a spinal cord stimulator and they didn't bill 2 leads, they only billed 1 lead, we wouldn't be able to determine if that was billed correctly or if it was coded correctly. So we're only determining what was billed and what was paid. So the steps to conduct for a reimbursement audit, first you got to determine your sample size, and it'll be dependent on the frequency of audit. The more often you're doing the audit, the less you'll have to have as your sample size. The more frequent, and obviously the less frequent you audit, you're going to have to take a larger sample size. You're going to have to run a report, and you're going to have a report that has some kind of unique identifier, whether it's account number, visit number, MRN. You'll need your contractual amounts. What is owed for each different CPT code for each different payer. You'll need to know how much, what the payment amount is and what the balance is. So when you're conducting reimbursement audits, most of the time you want to conduct these on zero balance visits or CPTs, right? Because if you still have balance, then it's really going to be hard to determine if you were paid correctly. But once they're zeroed out, that's the RCM staff is saying we are comfortable in how much we got paid for this visit. So those are the ones that you want to look at. Next, you want to review your payer contracts. Make sure you know the fee schedule of each of the CPT codes. Carve-outs. Sometimes carve-outs are different than the fee schedule. They'll say for these particular procedures, we're going to have a special amount. It could be a percentage charge. It could be something completely different than the fee schedule. I talked about, again, multiple procedure discounts where they're going to pay typically 100% on the first code, and then they may discount this subsequent codes. And finally, especially in the ambulatory surgery center world, different than the physician practice where, we'll get paid on implants on some payers. So you got to know how much they'll pay on implants if they pay at all. And again, you want to perform this audit on all zero balance accounts or visits. You want to compare the payment amount per CPT to contractual rates. And you want to take into account, again, the carve-outs, multiple procedure discounts, and implant reimbursement, if applicable. And if the variance exists, calculate the underpayment amount and the net collection rate, right? So if a variance exists, then your net collection rate is not going to be 100, right? It's going to be less. And so you can calculate that by how much we are supposed to how much we collected over how much we are supposed to collect. And then analyze your results. If your net collection rate is less than 97%, look at the root causes. Then you'll have to start digging deeper into it. And then you'll have to combine this audit with other audits, the ones we talked about. You may have to do, a follow-up audit, maybe a billing audit, maybe look at all the different audits then to determine why we're not collecting 97, 98, 99%. A low collection rate, again, may necessitate this further analysis. So this is really a first step. And then again, use this as a springboard to, if you have a low collection rate, use it as a springboard to conduct further audits and determine whether or not your billing office or your outsourced RCM company is really doing their job. So really, looking at the metrics, a practice or facility, they may have gold standard metrics across the board, but they still may be cash poor. So it's important to know the definition and what each metric means because they don't tell the entire story. Okay, you want to make sure you're utilizing different types of business office audits really to determine the true health of an organization.
Thank you, Michael. So what's really interesting is like you're saying there are all these different types of audits, and I appreciate going through the reimbursement one. It's definitely, you've made very clear why that is key. But I'm guessing that none of these audits work in a silo. You kind of got to use multiple audits together to really get a sense of what's going on. And especially now as we move over towards Colleen with the credentialing piece of it, how credentialing could be impacting your revenue management. I'm sure we'll see more different types of audits and how that can be used in conjunction to really get a full sense of the health of the organization, as you put it.
Yep, absolutely.
So Colleen, let's hop over to you now.
Thank you, Allie. And thank you, Garfunkel. I've had about 10 years of credentialing, direct credentialing and provider enrollment experience and was in billing before that. So I'm excited to be here to kind of explain what credentialing and provider enrollment is and build upon Michael's slides of how that can affect your revenue cycle. So starting off, what is credentialing and provider enrollment? Basically, it is gathering and verifying credentials for the entity, physicians, and medical professionals under the tax ID to ensure services will be safely and appropriately rendered. In terms of an ambulatory surgical center, you're looking at the entity itself, not as much as your independent physicians. Process of enabling medical physicians, professionals, and entities to participate in healthcare insurance networks while being reimbursed for their services provided under contractually agreed upon rates. Overall, it's that creating that link between the entity or the physicians to the insurances to ensure maximum reimbursement possible. Some of the items that you'll be looking for when I am referencing gathering and verifying credentials for an entity, some of those items would be your licensing or your operating certificates, any accreditations that the ASC might have that are requirements with payers to be contracted with them. If you have CLIA certificates, if you have general liability, if you do any accreditation for radiology or anything like that, you're going to need those pieces of information before you start that process. And that's going to come into key part of being in network with your insurance. For physician credentialing, you're going to look at more items like their licensing, their DEAs, their professional liability certificates, board certificates, CVs. Those are the types of information that provider enrollment really focuses on. The importance of credentialing and provider enrollment. So overall, why is it a necessity for your entity? Healthcare insurance networks now require in-depth, lengthy enrollment processes for most physician types across all specialty areas. It's not a cookie cutter situation anymore. It's not an easy process. It takes time. It takes a lot of follow-up. And a lot of times an entity, an ASC, they just aren't equipped with the amount of time that it takes to follow that process through, so nothing is dropped. Healthcare insurance networks frequently update and add new requirements to the enrollment process, making accuracy of application submissions vital to prompt approvals. Same, you don't want to be submitting old enrollments because you may not have had the time to review a new item or a new requirement or an application that only will push the approval process back. Extended processing times for enrollments can create potential net collection revenue loss as physicians wait to become approved and in-network. So that net collection coming in is going to take a hit if your physicians are waiting in that pending process with an insurance company if they haven't gotten their approval because something is missing or something wasn't submitted correctly. Specific demographic details such as service locations or clinic locations may affect reimbursement based on where physicians render services. So if you have more than one location in some instances, that does matter in a credentialing and provider enrollment sense, and the payers will take note of that and want the correct information on file. And the big piece is not maintaining your enrollment accuracy. This will cause non-compliance with contractual obligations and will result in loss of revenue if they conduct audits or they come back and you haven't done the necessary information or haven't done the necessary verifications that they require to keep you in network. They will end your participation status if you don't maintain their requirements for their credentialing process. So I wanted to speak a little bit about how credentialing ties to the revenue cycle process. Credentialing has a direct impact on the steady flow for reimbursement as it is one of the leading causes of financial loss. So like Michael had referenced the gross collection rate and when to look for that. As he mentioned, if you see a major drop in 1 month of a large percentage, this could be a red flag on the credentialing side that you may have been dropped from a network or a participation And that's something to definitely get ahead of as soon as possible. Don't wait the 3 months to see if that percentage is going to go anywhere. It could be a leading cause of, your credentialing could be a leading cause of that large impact that that's having. Utilizing different business office audits to help identify areas of revenue reduction due to credentialing issues, as well as identify compliance gaps. So same, going through what Michael had said about the audits, really utilizing those to pinpoint areas where credentialing may be causing issues that you're not aware of. Maintaining a transparent and up-to-date listing of each physician's health insurance network status, or in this case, the entity's network status, will increase revenue and allow staff to deliver the highest level of care for all patients. You want that transparency between your front staff all the way through, so patients are not being scheduled to be seen for insurances or big procedures that you're not in network with and you're going to lose revenue with. You want to be aware of what that is going to do in the long haul for you on the revenue side if you're taking patients that you're not yet approved for. One of the audits I wanted to take note of was the denial audits. Denial audits can help pinpoint possible credentialing inconsistencies. As these inconsistencies are found, it is vital for swift communication to appropriate staff in order to update the physician or entity's approved healthcare payer status. So those denial audits coming through are really going to show you where you need to look. If it's an overall denial where all your claims coming back are seeing some kind of mass denial, or if there's only certain physicians that may be seeing that, or certain services in an entity situation, it really will help gear you to look into those specific instances. Credentialing is often an extensive and lengthy process, which can cause an influx of denials without proper communication. So going back to that transparency between staff, the longer it takes you to correct your credentialing issues, the longer you're going to go without getting paid appropriately. So as soon as you see something happen, you want to act on it. The credentialing process in general is lengthy, so you don't want to wait because a lot of times they won't backdate certain processes and you'll lose out on that money. Common denials that might highlight credentialing issues that you may see come back, or if you're out of network with a particular payer, lack of prior authorization and invalid place of service. Those common denials, really, if you see those come back in bulk, you really want to be looking at the credentialing, make sure you're verifying with the healthcare payer that you're currently credentialed and contracted, and really seek out your contract language and make sure that you are set up appropriately to the way you're billing. If your contract is set up one way with a payer, but your billing has shifted and you're now billing maybe a different way, a different place of service, under a different provider in case of a group physician office, that is going to cause denials, and it is something that credentialing needs to be corrected for in order for that revenue to come back correctly. Reimbursement audits. Reimbursement audits can help identify if the practice and our physician are being paid correctly. Each healthcare payer has a contracted fee schedule that's agreed upon when the contract's executed during the process of becoming an in-network participating practice and or physician. So same, that entity is agreeing to a contracted fee schedule. Like Michael had said, you want to make sure that you are being paid what you should be being paid based on that contracted rate. So reimbursement audits can really help highlight that, that you may be being paid out of network when you're actually in network, and that could be caused by a credentialing issue. Many times when payments are not being compensated to the contracted fee, it is due to the issue with the enrollment of the entity. Additional service locations or clinics can also impact reimbursement totals, as they're not considered in-network under an executed contract if not credentialed properly. So if a second clinic is opened, that is treated as a separate entity. It's not something that gets included automatically within a contract that may already be executed. A lot of times we see that an entity may think they're contracted, we're good, we've been being paid for however many years, but it comes down to, well, we opened another location and we're billing it out the same, and that's where your issues are lying. The key points of some of the credentialing, provider enrollment overall is quickly growing to become a major complex process within the medical entities and are often overlooked or pushed to the side. Again, the offices or the entities don't have the time or the resources to really dive into what needs to be done and the amount of follow-up. It is truly, a key piece of your revenue cycle, though, to really dig deep in your credentialing and make sure that you're using those audits to see where those missing items lie. Compliant provider enrollment will positively impact the management of the revenue cycle process, leading to more productive and accurate reporting. So as you become more compliant with your contracted payers, it's only going to allow your audits to work more effectively for you. Miscredentialing details will lead to inconsistent revenue with limited recourse for recoupment of lost funds. So going back to, if your transparency is not there on your staff, those credentialing details will grow over time, and it will affect your revenue cycle coming in. And a lot of times that backdate won't be granted, and you'll lose that, ability to recoup those funds in all.
So just as a question for both of you, possibly even at this point, when the ASCs run an audit, whether it's the reimbursement audit, the denial audit, do you recommend just having sort of a basic, here's an audit process, very general, sort of high level, let's identify the problems, and then when you see there's some sort of dip, drilling down and doing a more intense, build out audit, adding more elements that might be unique to that specific facility? Or do you recommend, build your own process that builds in your uniqueness right off the bat?
You want to go ahead?
Go ahead.
I can take it. Okay, yeah, sure. I think it should be unique across, organizations. You develop your own process, but the general guideline should be, first determine if it was paid correctly. If everything's paid correctly, there's not much more that needs to be done, right, Ellie? But more often than not, you're going to find where it wasn't paid correctly, and then how you handle it. Do you review it with your staff? Do you have a meeting then and go over and talk about best practices? Obviously you need to make sure you do your combine it with some other audits to see what happened. Why aren't we being paid correctly? Because there may not be the RCM company or your staff's fault. There could be a very valid reason why it wasn't paid correctly, right? In the case of what Colleen just talked about, it could be that the credentialing was wrong, right? And so there was no way we were going to be paid correctly. So yeah, it's important to follow basic steps of the reimbursement audit and then going into different audits, but then how you handle and how you go about discussing it and reviewing a plan to limit those issues or errors moving forward is probably going to be best left to the organization.
Thank you.
Yeah. I just wanted to add in you're also make sure you're looking for, there could be a situation where in physician groups, even that individuals may have independent contracts with some insurances. So a lot of times the insurances may make mistakes on their end where they're paying you on a different fee schedule than what your fee schedule should be on what you're billing. So like Michael said, making sure you know your fee schedule for your entity that you're billing out for is crucial to make sure that that's coming back, because it could be paid in network on a fee schedule, just not the correct fee schedule for what you should be receiving.
So I guess just to wrap up here, let's do a little bit of an exercise now, Michael.
Sure. So after a discussion like this, I always like to, especially, keeping in mind that metrics, and probably should have started off by saying this, is, metrics never tell the entire story of an organization, right? So we're going to take this question is really geared toward how well you understand the metrics and determine which entity here is in the best financial position. So the list of hypothetical ambulatory surgery centers below, assuming charge masters are the same, which one is in the best financial position and why? So one that has, days in AR different, net collection rate, which we talked about in detail, percent of AR over 90 in detail, and then gross collection rates. I'm going to put Colleen and Allie on the spot here. Colleen, which one would you say A, B, or C, or first, second, and third is in the best financial position and why?
I would probably choose B, or the second one, because I'm looking at my net collection rate being 99%. And that's basically you getting paid what you should be getting paid. So I'm going to go with that one.
Okay. And Allie?
Okay. And I'm going to go with C, based on the gross collection rate. But I'm gonna
being the highest. Yeah. And so first to Colleen's answer, no one picked A, and so they're kind of middle of the road. Their days in AR are decent, but their net collection rate's pretty good. Gross collection rates okay. Percent of AR is really good. But to Colleen's point on B, most people select B because days in AR great. Net collection rates, fantastic, 99%. They only have 6% of AR over 90. But if you think about gross collection rate, now it's kind of a trick question because assuming charge masters are the same, so no provider, you're going to very rarely find two different providers with the same exact charge master. But let's assume they're the same. If charge masters are the same, that means your charges are exactly amount. Would you rather get 63% of of 100, if you have $100, would you rather get 63% of that, 74% of that, 69%? So the correct answer is Allie's answer is C, or the third one. And even though the metrics are not great in this center, they're still collecting 74 cents out of every dollar, whereas opposed to B, where they're collecting only 63 cents out of every dollar. And these are actual centers, and B was an actual center that I went to, and they said, nope, we're doing great, we're fine. My days in AR are great, net collection, and they had all the metrics that they measured every month, and they followed them very closely. But again, these understand that the metrics, all the metrics, even a net collection rate, can be manipulated by any kind of biller or collector worth their grain of salt. So it's really, at the end of the day, a center or a practice can still be, metric can be great, but still be cash poor. And that's the case in B. But C, their metrics are not great, but they are still collecting more than any other center. So, Ellie, you got the correct answer.
All right. Well, thank you, both of you. This has been really informative. I hope everyone found it as informative as I did. And I want to invite everybody to join us later on for the live Q&A, which will be happening at 3:30. You can come with your questions, and we look forward to rejoining you then.
Thank you, Allie.
Bye-bye.